Hi, I'm Thanu Rao, and today I want to talk about different kinds of bowel endometriosis. So, the first case is of small bowel involvement. We know that in literature, the incidence of involvement of small bowel is not as much and is quoted to be around 6 to 10% in women in reproductive age group. Now, this is a case of a woman who has a multifibroid uterus, as you can see, and also has a left endometrioma. But surprisingly enough, when we went to push the bowels, especially the small bowels, up into the upper quadrant so that we can get access to operate, there you can see it. There is a nice endometriotic nodule over there involving the ileum. In fact, this was a bit isolated and not picked up by imaging, which was MRI in this case. Hence, it's really important to have a 360-degree view of the pelvis when you do endometriosis cases. Now, this is post-hysterectomy and unilateral oophorectomy, and really we're trying to see, can we just get away with shavings? You can see over here there are 2 loops of bowels that are there, and they're quite matted. So this is around 10 centimeters from the ileocecal junction, which is why we then decided to do a small bowel resection and anastomosis. If it's a bit closer to the cecal junction, then you'll probably have to do a cecal resection and take a call regarding whether you want to give rest to the bowel or not. This is us still trying to see whether we can separate the loops of the bowel, but as you can see, they're densely stuck. So this one nodule of endometriosis has matted 2 loops together, just making them inseparable, which if left alone can be a bit harmful. And this is the pathology. You can see extensive endometriosis with serosal adhesions and the rest of the pathology, as you can see. Now, with case 2, this is where the appendix is involved. Literature actually quotes the appendix to be involved with an incidence of 2.6 to 13.2%. But I've recently attended the AGES conference just yesterday, and we had a paper presentation where this is a group from Sydney, Dr. Nickham, who has quoted it to be around 40%, and in fact their recommendation is with stage 3 and stage 4 endometriosis, consider appendicectomy at the same time. Now, this is a lovely lady who has had right endometrioma. In fact, it's formed a tubo-ovarian complex treated as pelvic inflammatory disease, but then we figured out that this is actually an endometriosis. And we did consent her for appendicectomy, and as you can see, the appendix was a bit retroperitonized, but overall we managed to take it out, and it turns out that this also confirmed it to be endometriosis. So the presentation may not be acute, and the histopath may not confirm acute endometriosis of the appendix, but nevertheless taking it out does have its merits, especially if it looks to be a bit involved. Now, whether to do it as a routine in stage 3 and stage 4, I will leave it up to you guys and see what your practice dictates, but there are some groups of surgeons advocating for the same. Once the appendix is trimmed down to the base, you put around 2 endoloops, and then you cut it. Sometimes this can be actually quite tricky, and it's important to involve appendicectomy in the consent form as well. When they come as an acute presentation of especially a right tubo-ovarian mass, endometriosis or pelvic inflammatory disease, usually what I tend to see is the tip of the appendix is pulled along into that mass. So it's always a good practice point to counsel the woman that there is a small chance of appendiceal involvement, and if need be, we might be able to take it out in the same setting. Both the cyst and tube were retrieved in a bag, and the histopathology, as you can see over here, has confirmed it to be endometriosis. Now, surprisingly, there was obliteration of the lumen over here as well, and you can see that's involved the serosa and the muscularis. So it's a bit of deep endometriosis. Thus, I cannot emphasize enough how important it is to have a really good colorectal surgeon on your team. And now the last case, which we often see, that is involving the large bowel. Often it's the sigmoid or the rectum. So sometimes it can be a bit clean, especially if it involves the rectum. So as seen over here, it's a low point of adhesion, usually at the point of uterine torus. And as you can see over here, with good instruments and good assistance and teamwork, usually it is an avascular plane that you can find out and separate the rectum from the vagina. It also depends on the type of nodule that's there. So in this woman, thankfully, she just had superficial serosal involvement, nothing deep that involved the muscularis or the mucosa. But at times, not so lucky, you actually see a bit of involvement with the endometriotic nodule, as seen in our next case. So this is a case of a 10 centimeter cervical fibroid, and as you can see, the sigmoid is attached right starting from the fundus, and it goes all the way down around 3 to 4 centimeters segment of this entire sigmoid was plastered to the uterus and down below to the rectum as well. So at times you wonder whether you've made the right choices. In any case, we got through it and completed it laparoscopically as well. These are the different kinds of bowel endometriosis we find. I hope this has been useful, and I'll be back with more videos. Stay tuned.